Hello, my name is Roger Packer, and I'm Senior VP of Neuroscience and Behavioral Medicine, Director of the Brain Tumor Institute, and Director of the Gilbert Neurofibromatosis Institute at Children's National Hospital in Washington, D.C. And it's my pleasure to give this presentation, New Horizons in the Management of Neurofibromatosis Type 1, Associated Plexiform Neurofibromas, and Gliomas. These are my disclaimers, and this is my potential conflicts of interest. We're going to be talking about neurofibromatosis and new therapeutic approaches. The incidence of neurofibromatosis is 1 in 3,000. Although it is a relatively rare disease, it is certainly something that you can encounter relatively frequently in a practice. It occurs in all races and ethnic groups and occurs in both sexes equally. The diagnostic criteria for neurofibromatosis remains a clinical one. The predominant findings is 6 or more brown spots called cafe au lait spots, which are greater than 1.5 centimeters in postpubertal individuals, but smaller in prepubertal individuals. And one of these other factors that you see, including axial or inguinal freckling, 2 or more neurofibromas, specific tumor types, or a first-degree relative with NF1. Now, these criteria have stayed in place now since the mid-1980s and really have been the basis of most of the studies that have been done on children with neurofibromatosis type 1 and adults. And there are other things that may be helpful in the diagnosis. These are what the cafe au lait spots look like. In the older patient, there tend to be large, brown, relatively regular spots. Sometimes it can be a little bit irregular, sometimes it can be oval. And the development of these kind of signs and symptoms is really age dependent. 95% of children can be clinically diagnosed by 6 years of age. There is overlap with other syndromes such as Legia syndrome, where you can have the cafe au lait spots, but not develop the intracranial tumors or the plexiform tumors. An entity called mismatch repair, where you may have cafe au lait spots, but develop intracranial tumors, including high-grade and low-grade gliomas. This is one of the kind of entities that is often diagnostically confused with NF1. And one of the questions that is raised is what is the role of other kinds of testing to help make this clinical diagnosis? MRI can be useful, which we'll show you in an MRI in a second. It can show areas of abnormal signal throughout the brain, has some specificity in younger patients, although goes away actually as the brain matures. These areas of abnormal signal are probably maturation delay areas, and they are not tumors. And they are very helpful sometimes in a questionable case. They are not part of the absolute accepted diagnostic criteria. Genetic testing is more widely available. Not all laboratories are equal, but up to 95% of confirmed cases can be proven to have some mutation in the NF1 gene. Now, this requires quite a bit of different genetic evaluation, and that's why not all the laboratories are able to do this. At the same time, it is not something that we use unless we are in an area where we're a bit confused about the diagnosis. This is what the abnormal signals of intensity are in NF1. These are whitish areas, and if you don't really know the entity, you might confuse these with tumors. They do not usually have mass effect. They don't enhance when gadolinium is there. And the other thing that's very interesting is that these disappear over time, that you have many more when you're 5 or 6 than you have when you're pubertal or post-pubertal. Interestingly, they do seem to increase this apparent abnormality in the brain over the first few years of life, and that increase can confuse people that they might be tumors. There's also a very poor genotype-phenotype correlate for most of the mutations you see in NF1. There's a few types of mutations, such as the microdeletion, that have a different kind of phenotype, with more chances of developing tumors and more cognitive issues. But most of the genetic abnormalities do not have a clear-cut phenotypic correlate. As far as management for NF1, there are many different clinical manifestations. We're going to focus on the neurofibromas and the gliomas, and we'll talk a little bit about the malignant peripheral nerve sheath tumors. Just to just to state it, learning problems, including cognitive issues, behavioral issues, attentional issues, are very common in children and adults with NF, and up to 60% of patients will have some degree of learning disabilities. However, neurofibromas and gliomas, although less common, are significant problems that we often have to deal with. The real issues as you go along any of these problems is how do you treat these issues? Can you just treat the symptom, or can we do better? Can we actually get down and change the biology of the tumor? When do we use imaging? And when we start using therapies, what is the acute versus the chronic benefit of the therapy versus the acute versus chronic toxicity of the treatment itself? So are you going to get enough benefit to deal with the toxicities? Are you going to get lifelong or short-term benefit? And one of the things we try to factor in, and it's very difficult, is the erratic natural history of this disease. If you really can't predict how this disease is going to progress, how do you know your treatment is working? One of the major breakthroughs in NF is the understanding of what the NF gene loss, that mutation, does. And this is something that's been discovered over the past 2 decades, that the NF gene is a major controller of signaling along the RAS MAP kinase pathway. And when this pathway is activated, you can have uncontrolled proliferation. When neurofibroma is gone, the pathway is more activated. There can be also concomitant signaling on the PI3 kinase pathway, but honestly, most of the data of efficacy of some of our new drugs is targeting this abnormality. There have been a variety of different ways that people have attempted to target that pathway in patients with neurofibromatosis type 1. Many of these have not worked, but the one that we will focus on will be direct signaling down that pathway. And when we take a look at drugs that have tried to be targeted up earlier in the pathway and drugs that have been used later in the pathway, the one where we've had the vast majority of the benefit has been directly targeting this RAS MAP kinase abnormal signaling, and specifically targeting MEK, which is one below BRAF in the pathway and a major controller of the pathway. And the serendipity that was found in this disease is that already work was underway trying to target this pathway in other conditions, not only in NF, but in other conditions such as melanoma. So there were a series of drugs available that could target that pathway. So the first thing we'll talk about are the neurofibromas. These are a heterogeneous group of lesions with different morphologies. They arise from both large and small nerves. They're composed of Schwann cells and fibroblasts, grow at variable rates in many locations. And there really isn't a standard neurofibroma classification system, although we're coming closer. And this is what people are using now. This came out of the workshop at the NCI, the dermal neurofibromas, the plexiform neurofibromas, the atypical tumors, and the malignant peripheral nerve sheath tumors. And the thought is that the plexiforms, atypical, and malignant peripheral nerve sheath tumors may in one sense be a continuum where the loss of NF1 underlies the plexiform. When you get CDKN2A mutations on top of that, you may get into an atypical neurofibroma. And then when you get into other mutations, including P53, it turns into malignant peripheral nerve sheath tumor. Now, we've known that these tumors can be quite disfiguring. We also know that they can cause neurologic problems and pain, and depending on location, other issues. And we've also known that they tend to grow, and excellent work done by Dr. Wiedemann and Dr. Dombey at the NCI in the United States in a series of 40 patients showed that these tumors did, especially in children, increase in size over time. About 50% of them and 50% of patients did have this increase. And this increase in size could be targeted. These tumors can cause serious morbidity, as in this head and neck tumor. This is one that is compressing and moving the trachea over. This is one that's along the spinal cord. These can be very neurologically, cosmetically, and physically damaging. And some, as in this plexiform that involves the pelvis, can cause quite a bit of bowel and bladder problems. One of the things we fear most is this transition to malignant peripheral nerve sheath tumors and trying to pick up this transition early so we could target treatment. Now, what has been the experience in treating these tumors? Well, until recently, it's been very frustrating. A variety of different chemotherapies and then molecular targeted therapies have been tried. And taking a look, there can be some prolongation of time to progression, but the actual shrinkage is very uncommon with drugs such as sirolimus, which is an mTOR inhibitor. Interferon did delay progression in some patients, but did not result in much response. And there was a lot of excitement for a period of time that imatinib would be effective, but it only works in a small group of the patients. But once again, we had these MEK inhibitors, and this is where the therapeutic entity really changed dramatically. Work coming out of laboratories around the world, including this one by Nancy Ratner, the University of Cincinnati, showed that the use of one compound, the Pfizer MEK inhibitor, in animal models could show shrinkage of the tumor. This is waterfall plots. This is as the controls, you could see the tumors got larger over time, but at various different doses of this MEK inhibitor, you could see these reductions in tumor size of plexiform neurofibromas going from 20% to as high as 80%. This is the first time we've even seen that in an animal model. This led to the first study, the phase 1 study done at the National Cancer Institute, led by Dr. Wiedemann and Dr. Dombey, trying to determine the dose of the MEK inhibitor sulimetinib if it was going to be used in plexiform neurofibromas. And the startling responses seen in this phase 1 study really surprised everyone. Phase 1 studies are used to determine dose, and yet we were seeing this dramatic shrinkage in some patients. This is what the phase 1 study looked like, and this again is a waterfall plot, and you can see how much these tumors shrunk using 20% as the bar over the majority of them, greater than about 75%, had a reduction of greater than 20% in this phase 1 study. And side effects, although significant, rash, gastrointestinal, asymptomatic CPK elevation, were tolerable. This led to the crucial second phase 2 study called the SPRINT trial, which brought in 50 children and with neurofibromatosis, a median age of 10.2 years, with a male-female ratio of 20 to 30, with some of the children having progressive disease, some having symptomatic disease that weren't progressive, and others we weren't really sure how progressive they were on the study, treating relatively large volume plexiform neurofibromas, the median almost 500 cc's. And this was the results that were published a variety of different times, and dramatic results that we saw that about, again, 70% of patients had some amount of shrinkage of these tumors, often associated with clinical benefit. And on the basis of this, the drug was approved, and it's the only drug approved for use in plexiform neurofibromas. Now, there have been other drugs that have been attempted. Trametinib is another MEK inhibitor by another company, which shows a reasonable objective response rate of about 50%, not quite as high, same kind of side effects, but only 3 patients in this study had to discontinue due to the acne and the skin toxicities. And another study of the MEK inhibitor from Pfizer also was recently completed and showed again that the majority of patients do have benefit, and the majority have that benefit as long as they're on treatment. Many of these plexiforms, unfortunately, relapse when treatment is stopped. Other drugs that have been used for plexiforms recently include a multi-kinase inhibitor, cabozantinib, which has also shown some benefits. And there are now trials trying to combine these drugs together, but there's no question that the AstraZeneca sulimetinib drug has been a very effective treatment. Just going a little bit farther into the treatment of NF, one of the other major manifestations of NF are low-grade gliomas that can occur in as high as 20% of children with NF1. This is a difficult tumor to treat because we're not always sure exactly what are we treating. Is this going to be a chronic disease? Is there going to be a lot of deterioration in the visual pathway? Is there going to be a lot of morbidity? And we're always questioning, are we treating the child or the neuroimage? But looking at this, the standard treatment for this was chemotherapy with drugs such as carboplatin and vincristine. And we did know in the NF patients that these drugs were frequently of some benefit, with about 70% of patients having at least stable disease 3 to 5 years from treatment, and about 30 to 40 showing objective shrinkage on treatment. There was also some data with bevacizumab and irinotecan, and probably the most important thing we learned from this early experience, that sometimes with these molecular targeted therapies, bevacizumab and anti-blood vessel agent, you could see some of the most dramatic responses we've seen in years. And more importantly, with some of these molecular targeted therapies, we could see reversal in long-term neurologic deficits, such as this child with a field cut, where this is the visual field that's been lost with this chiasmatic tumor, on treatment showing dramatic improvement. Unfortunately, with the bevacizumab, the benefit was only for as long as you stayed on the drug, and there were some side effects such as proteinuria and high blood pressure that were difficult to maintain the drug in long term. So the data that then broke out in the last decade was a majority of pediatric low-grade astrocytomas called polycytic astrocytomas are driven by the RAS-MAP kinase pathway, including NF1. And once again, we have the MEK inhibitors to try to overcome that over-signaling through that pathway. And this is some of the preliminary results in the phase 1 we saw, with the tumors starting to disappear on MEK therapy, and some of these disappearances being dramatic. When we look at the same waterfall plots in patients with neurofibromatosis, type 1 and low-grade gliomas, they're very similar to what we saw in the Plexiform neurofibromas. The majority of patients, especially on this side, are the children with NF1, have response. And if we use that 20% bar, again, it's about 70%. And if we use the more classic 50% bar for children with intracranial tumors, it's still about 40%, with the majority having some benefit. And one of the more interesting things about this experience is that there's been durability of response, that in patients with refractory or progressive low-grade gliomas, when we treat them for 1 to 2 years with a sulimetinib, the majority in NF1 maintain their response for years after we stop treatment. Not all, but some do. And now this is a prospective study for children with NF1 being compared to chemotherapy, being run through the Children's Oncology Group and soon internationally. So as we take a look at plexiforms and low-grade gliomas and try to summarize it, in many ways, this is the largest advance we've seen since chemotherapy. This is misprint 4 low-grade gliomas. It's the first reliably effective therapy for plexiform neurofibromas, and at least in the majority is tolerable. There's a learning curve of using it. There's a lot of rash with this drug that you've got to learn to use, especially in pubertal patients. There's weight gain, especially in girls who are pubertal, and there are CPK elevations that can be worrisome, but overall fairly well tolerated and usually asymptomatic. The real question is, will these drugs result in functional improvement they have in the plexiforms? We believe they will improve visual outcome in some patients with low-grade gliomas, and only these randomized studies, especially for the low-grade gliomas, will give us the full picture. There are a variety of different drugs, although the sulometinib drug is the only drug that's approved yet in plexiforms. Certainly other drugs are being used off-label. It's not clear which drug is going to be the most effective. They have similar efficacy, although the sulometinib drug for plexiforms seems to have the greatest response rate. These drugs have different molecular structures, and the question, will they have different functional outcomes? Also, will toxicity vary? And the real biggest question with these drugs are, what is the impact of these drugs on overall brain and other types of development? Preliminarily, our studies have shown in NF no detrimental effects of the drug, and actually some improvement in some cognitive functioning after being on the drugs for up to a year. What is going to be these functional outcomes? Are combination therapies going to be needed in NF1? What is the effect of the MEK inhibitors on the natural history of low-grade gliomas and plexiforms? We expect that many of these tumors will slow their growth or stop growing in the child after puberty. Are we going to affect that detrimentally by trying to shut down these mechanisms early in life and lose some of our feedback loops? That's going to be an issue. And is this preparation going to be available for young children? The AstraZeneca drug, the sulometinib, is only available in oral preparation, that in capsules and tablets. We cannot chew those. Sprinkles may be available over time. Other drugs are potentially available in liquid formulation. And as we talk, the use of chemotherapy or other ways to try to overcome resistance, and these studies are underway. So finally, if these patients go on these drugs, especially sulometinib, there is a way to report adverse events or product quality complaints. I thank you for your attention and appreciate the opportunity to present this data on the use of the MEK inhibitors for both plexiforms and for low-grade gliomas in patients with NF. There is growing data about the utility of these drugs in the non-NF population of low-grade gliomas, and we really think that we're still scratching the surface how we best use these drugs and learn how to use them to benefit patients in the long term. Thank you very much for your time and your attention, and I'm happy to take any questions.